format with Reza and I discussing a case today, and um, we would love for a case presenter to join us. In the meantime, I'll pass the mic to Prof. Rez at his yellow couch to say hello.
Hello, hello, hello. Welcome back, everyone. Very excited for today's case. And I can't wait for someone to volunteer so we can get some great teaching going on. Thank you, Alec. We got some Kobe Jordan in the background. Well, yeah, Robbie, yesterday I got a chance to play some soccer with some undergrads, and I barely could move this morning. It was a struggle.
Sriram, I love that. Rizaldo, did you hear that? You see that in the chat?
Oh, what happened?
Oh, so good. I also see Rizaldo. Yes, I love it, Sriram. That's so good. Amr, I haven't seen you for ages. Welcome back. How are you? Amr's one word, very concise response is he's great, just so everybody knows.
Well, it's great to be back.
There you go.
The timing has been quite different for me, and I was quite busy lately. But it's always great to be back and see all these amazing faces every day.
Incredible. What are you up to now? Where are you at with your training?
I finished. I graduated a few months ago, and I got my UK registration, and also I'm in the process of applying for the US MLE, but it's taken ages for the verification, so I don't know if that will happen.
Gosh. Yeah. Well, congratulations on graduating, a huge milestone.
Thank you very much.
So we can call you Dr. Amr Musa now, right? Is that right?
After I treat one patient, I feel
okay. All right. Well,
like I just want to help one human being.
Maybe we can count today's virtual case. How about that? So whoever has the privilege of presenting will be presenting to the first and only Dr. Amr Musa.
I would love to volunteer. Thank you.
Right,
and I actually don't believe that you remembered me.
Oh, are you kidding? Of course. How could I forget? You've been here for so many instances. All right. Anyone have a case? Going once. Going twice.
I knew it. I actually knew it, Alec. Alec, welcome back. It's been a while since I've seen you on this forum. Do you mind unmuting yourself and telling the audience a little bit about yourself?
Hey, I'm Alec. I'm Alec Razai. This is my second year as a hospitalist at Baylor. And yeah, it's been a while since I've been on my VMR besides yesterday, but I feel like every time I come, I just, no one volunteers. So I just feel like a little stuck, yeah.
And I recently had an amazing dinner with your twin brother in Los Angeles. And I didn't know he was going to pay for it. So I suggested a mediocre place. Had I known he was going to pay for it, I would have went for the $3 signs on Yelp.
He said he enjoyed it. So
it was lovely.
Nice to meet you and Liz. So
you ready to get going? Heather, can you take over the screen to start scribing, and then whenever the screen is up, Alec, if you don't mind, start presenting, and I will tackle the first aliquot.
Sure.
With the permission of Robbie.
With the permission of Robbie. Do you want weakness and rash, or you want fatigue and palpitations?
I will defer to the audience. What do you want, our lovely team members?
Yo, since it's Amr's first time treating a patient, Amr, what do you want?
I feel like rash and weakness could be some autoimmune problem. Is something I love.
Alrighty, Dr. Amr Musa, this is your first patient. Remember it for the rest of your life.
Let's go.
All right, so this is a 50-year-old woman presenting with leg weakness and a rash. And if I'm speaking too fast, please let me know and I'll slow down. But so she reports she was feeling well until 2 weeks prior to presentation, when she started noticing some swelling of her left eye. She didn't have any pain, photophobia, or changes in her vision. And she's also noted a progressive red and itchy rash, like all over her face and her scalp, and then down to her neck and upper back. And she's had some associated dysphagia and odynophagia of solids as well. And thinks maybe she had a rash on her tongue also, but wasn't really sure. And has lost 10 pounds of during this 2-week period. And I'll stop there.
All right. We got a lot of data here. Maybe what I'll do is tackle the weakness and leave the rest for Robbie to untangle. And I think right away, we notice this is a young individual, relatively young, middle-aged, who's presenting with a chief concern for weakness. Most often in primary care clinic where Austin practices, who is Alex's brother, most often weakness is just a sensation of weakness, meaning the person just feels fatigue, but doesn't actually have true decrease in power, in strength, referred to as asthenia. But even if you took out everything in this case, the rash, the swelling, the weight loss, I would be concerned for true weakness. Why? Because the patient is so specific that they're saying my leg is weak. Usually when someone feels fatigue or has asthenia, they have this sort of full body sense. They don't really pinpoint to where the weakness is. So now we have every reason, supported by the background data, to approach this as true weakness. Now, what's really important here is that the pathologic process is not only residing within the muscles. We're already getting a flavor for hits on multiple organs, including the skin, including the muscle, and maybe more that we'll uncover as we get more data. So now that we've transitioned to tackling this as a neurologic problem, step one is trying to localize the site of neuropathology. And then step two is using the time course to prioritize the DDX. This is Aaron Berkowitz's neurology DDX, my favorite math equation. And I will just say this, because we don't have enough data yet. The main branch point is to ask, is this upper motor neuron or lower motor neuron? Meaning, is it the brain, the cerebellum, the spinal cord, or is it the peripheral nervous system, including the peripheral nerves, the junction, the muscle? Or is it somewhere in the in-between zone with both upper motor neuron features and lower motor neuron features? What's going to be really helpful is the physical exam, looking at reflexes, looking for spasticity, fasciculations, and then just muscle bulk. But I'll leave it at there. That's sort of your 5-minute approach to weakness.
Oh my God, 5 minutes. You needed a couple more minutes to get it to 5, my friend. That was so brief and concise and very, very rich. And you know, I think the other main dimension of this is the rash. And the truth is that none of us, unless we're dermatologists, are experts in rash. So we have to kind of keep things simple. And the simple approach is to first get a sense of the extent of the problem. And what that means is you first want to get the width of the rash, which refers to the spread across the skin and mucosal surfaces. So how wide is it, or how extensive is it? And then how deep is it? It seems intuitive that knowing how wide a rash is, how extensive it is easier than how deep it is, but that may not be true. But first, depth is inferred by degree of pain. The deeper it is, the more painful it is. And depth is inferred by the presence of ulcerations or presence of nodules. So something that is really painful is probably hitting the nerves, it's probably dermal, and it's probably deep. If something has caused a significant ulceration, that's deep. And something is nodular, it's also distinct from the dermis. So those are red flags for with regards to depth. That seems harder to do for a non-trained expert than width, but the width is actually also tricky too. Because there are places where a rash can very easily hide in the armpits and the intertriginal areas behind the knees, and things that are subtle that you may think is just background skin disease may actually turn out to be a really important clue. So with that context, we have to ask ourselves, well, what is this rash on the face? And the facial involvement immediately for me reflexively invokes a couple of things I never want to miss. And those things are zoster, facial cellulitis, or an odontogenic disease process. All three of those things are pretty common. So if you tell me somebody has a rash on their face, I'll tell you, tell me what their status of their teeth is. Do you think it's zoster based on the appearance? And if not, is it demarcated in a manner that would suggest cellulitis? But there's also some life-threatening diagnoses to make sure you're not missing, including the possibility of SVC syndrome and angioedema or anaphylaxis. That's my checklist. So the three common ones and the three scary ones. The common ones are zoster, cellulitis, and odontogenic infection, and the three rare ones are angioedema, anaphylaxis, and SVC syndrome. But here, you're armed with much more data. This is a rash that's present on the face surrounding the left eye that has associated muscle issues, invoking very early the possibility of dermatomyositis. Now, why is that important? The probability of dermatomyositis at this juncture is 0.000001. It's very low. But there are some very subtle findings of dermatomyositis that would make that probability much higher. So if I heard the story, I would be intrigued and I'd be like, oh, let me look at knuckles. How often do I look closely at knuckles? Almost never. But in this case, I would. In this case, I would look very closely at the neck to make sure that there isn't a subtle Shaw sign, or look closely at the thighs to make sure there isn't a Holster sign. So I think this case is a reminder that you must be anchored in the base rate of the disease, and the base rate for facial rash is what I told you: zoster, cellulitis, and odontogenic disease process. But the combination of these things is making me look at subtle places that a rash that I would easily overlook: the neck, the knuckles, and the lateral thighs. In terms of all the other stuff, the 10-pound weight loss is really the main one. And as we've talked about, all it does is it tells us we need to get an answer quick. The weight loss doesn't offer specificity as to what's going on. It just accelerates the tempo. So basically, weight loss is the equivalent of sinus tachycardia for a chronic disease, which by definition this has to be. So I think the money is where Reza and Austin have dinner. Follow the neuromuscular lesion. We're better at that. We're better at localizing. So I would spend a lot of time figuring out what this dysphagia is, but not miss subtle clues from the rash. All right, Alec, back to you.
Awesome. And Reza, just so you know, Austin never pays for my food, so you're blessed. Okay. But I'll give you a little bit more information. So she was seen by her primary care doctor, like right at the beginning of her symptoms, who prescribed her some cephalexin, some antibiotic eye drops, and some what sounds like a corticosteroid cream for her skin. And she didn't note any improvement in her symptoms. And about 5 days prior to presentation, she began noticing difficulty with standing up and leg weakness when she was walking around, but she didn't have any falls or anything like that. And the review systems was otherwise completely negative: no fevers, chills, other infectious symptoms. She hadn't had any recent travel or sick contacts. So I'll give you a little bit more in regards to her other history. So in regards to other medical history of type 2 diabetes, no other real medical history, no surgeries in the past. And as far as medications, she takes metformin, 500 milligrams twice a day, and takes atorvastatin, 40 milligrams at night. She doesn't have any allergies. Family history-wise, has a father with lung cancer, but no other family history. And in regards to her social history, no tobacco, alcohol, or drug use. She is originally from Honduras, but she's lived in the US for about 30 years. And she previously worked as a house cleaner, but stopped working probably about 6 months ago, just for unrelated reasons. And I can stop there, or I can give you the physical examination.
This is super helpful. Alec, maybe I can just reflect on the additional data on the HPI, which I think gives clarity to what Reza started us on, and then pass the mic to him to reflect on the background. And I think it's really helpful. You know, I think PCPs have the hardest job in the world, because diagnosing an illness from the first few moments is so incredibly hard. And two, I think they hold the most humble recognition that the most common presentation of any illness is a common presentation of a common disease, followed by an uncommon presentation of a common disease. And here you can see that action, that knowledge being enacted by the PCP, who's like, you know what, topical atopic disease is so common, contact dermatitis, so is bacterial cellulitis. So whatever this looks like, you got to try some Keflex and some steroids, and it not improving is both a practical move, but also helps us so much make those two pretty common diagnoses much less likely. And the story of the leg weakness further reinforces this this notion that something unusual is happening here. Because you could easily say that somebody who has a big rash and a prominent rash may not have the easiest time to swallow, simply because it hurts to swallow, maybe. So anchored in practicality, I think that's a smart move. But when the legs are involved, the calculus changes dramatically. And I think when both the face and the legs are involved, you can make a pretty significant assumption that unless there is concomitant severe encephalopathy, the brain is spared. And that disease in the brain is very unlikely. Similarly, the disease in the spinal cord is very unlikely, because the cranial nerves would have to be involved. So because the neurological weakness is so far from each other, head and leg, it's much more likely to be in the peripheral nervous system. And you gave us one clue as to where in the peripheral nervous system by saying that she had a hard time standing up. So the muscles required to stand up are proximal in nature, and proximal disease suggests a muscle issue. It's not universal. A proximal muscle issue can also be a neuromuscular junction issue, especially on the muscular side. So myasthenia gravis, especially with the facial symptoms, shouldn't be put away just because it's proximal. So I think the flavor that we get is, yes, this disease is behaving in VMR style as opposed to real life style. And that proximal nature, which is not confirmed but suggested, puts us in the muscle greater than neuromuscular junction space. All right, I'll hand the mic to Prof. Rez for anything else that caught his eye and the background.
Thank you so much, Robbie. I think for the background data, Alec, what has grabbed my attention is the type 2 diabetes. Understand that diabetes can have so many different manifestations when it comes to neurologic syndromes or neuromuscular syndromes, from diabetic myonecrosis to amyotrophic myopathy. I can do several things. So I note that, but it wouldn't explain the rash, the eye swelling, not consistent with it. Then I see the patients on a torvastatin. We know with this torvastatin, a very minority of the population, very minority, it should never deter anyone from prescribing a torva, may develop antibodies to HMG-CoA reductase, which then causes this rip-roaring, severe necrotizing myositis. But again, this wouldn't explain the rash, and it wouldn't explain the eye swelling. That's like specific to the muscle. And then finally, her work as a housekeeper may expose her to chemicals that can have sequela, you know, in the long term. So I'm just tracking that. And yeah, that's all I have to say about the background data. Very excited for the physical exam.
All right, I'm happy to provide that. So in regards to the physical examination, vital signs, she was afebrile. Heart rate was 85. Blood pressure was 125 over 85. And respiratory rate was 18. And she was saturating 98% on room air. And her BMI is 32. So just in general, she's alert. She wasn't in any distress, was speaking full sentences comfortably. Her extraocular movements were all intact. Her pupils were equally round and reactive. Her conjunctiva didn't have any icterus. In regards to her mouth, her mucous membranes were moist. There was no exudates that I could appreciate. Her teeth actually looked pretty good. And her neck was supple otherwise. Respiratory wise, her lungs were clear, no wheezes, bronchi, or crackles that I could appreciate. Her cardiac exam was also unremarkable, regular rate, no murmurs. And her abdominal exam was equally unremarkable. In regards to her musculoskeletal exam, she had no joint tenderness, deformity, swelling, any synovitis in her hands that I could appreciate. And although she described lower extremity edema, she didn't really have any at all. And in regards to her neurologic exam, she was fully alert and oriented. She had no sensory changes. She had normal and symmetric reflexes throughout. And her strength was like 4++ out of 5 in the proximal lower extremities. And that was just me doing it a lot. But otherwise, her strength was completely intact. Really nothing there. And the remainder of the neurologic exam was unremarkable. And then I'll give you a more detailed skin examination from a non-dermatologist. So she had some erythema over her forehead and the cheeks, which to me looked like it included the nasolabial folds. And she had a little bit of redness on the front of her chest and then a little bit around the back of her neck. Although I would say the back of the neck looked a little bit more hyperpigmented than erythematous, but was still there. And she had nothing on her hands, nothing on the rest of her body, nothing on her thighs, nowhere else. And no finger lesions or anything else. And that was my physical examination.
Awesome. Thank you so much, Alec. I will tackle the weakness and then let Robbie tackle the rash as we're moving in parallel. I think something very important just happened when Alec presented this. We as providers are really good at identifying extreme abnormalities in the physical exam. So if the JVP is 14 centimeters, it's descended, we'll detect that. But what if the JVP is just slightly descended? If you take 100 cardiologists, maybe 50 will say descended, 50 will say it's normal. There's significant inter-observer variability. Where I'm going with this is that the neurologic exam is like any other exam. It's like palpating a spleen. If it's massive, maybe I'll be able to palpate it. And it depends on the examiner's skill. I would strongly argue that most of us will not be able to pick up subtle neurologic findings. I think the reflexes being normal takes us away from an upper motor neuron or a peripheral nerve process, meaning that we're not getting much signal for weakness. Hey, Robbie, I keep getting the alert, don't close CPRS in the middle of my discussion. By the way, I love CPR. I don't know why everyone complains about CPR. To me, it's better than Epic. But anyways, we'll leave that for a different discussion. So for me, what this exam does, I just fall back on what the patient was, concerned about, and that was weakness. So even though my exam doesn't pick it up significantly, I am sending the CK, the aldolase, the LDH. I'm looking at the AST because I'm worried about a myositis. I'll leave it at that. In fact, even if the enzymes are normal, because she really says that it's hard for me to get up, this is a person that have a low threshold for an EMG and nerve conduction study because it can pick up stuff that I'll never be able to pick up on physical exam that might be very relevant to the final DX. To you, my friend, Robbie.
Beautiful, absolutely beautiful. I love that point about the severity of the abnormality influences our detection rate. And if you're an expert, you might pick up more subtle things, but if a non-expert, you probably won't pick up overtly subtle things. And I think that's the analysis of the rash. I mean, if you look at this and you're like, there's erythema across the forehead, including the nasolabial folds, and there's retinas on the chest. That is a classic description of one of the most common rashes we see, which is seborrheic dermatitis. Most of that is idiopathic, but a fraction of it is related to some systemic disease, and the short list is Parkinson's and HIV. So immediately I'm like, oh, you know, I know we're on the autoimmune train because most most sexy muscle diseases are autoimmune. There's very few infections that cause muscle disease, but practically speaking, this could be very well consistent with seborrheic dermatitis, with the one caveat being that most seborrheic dermatitis is associated with scaling, which this patient doesn't seem to have. And again, I think the involvement of the face and neck here labels this as possibly a muscle and skin issue. In other words, dermatomyositis, but you have to be humble. Most, not just because dermatomyositis involves the muscle and the skin doesn't mean it's the only disease that involves the muscle and skin. So what would I be doing in real life? I probably would have missed the subtle weakness unless only the patient emphasized it, which here she did. But imagine if her chief complaint was rash, you might not have picked up the muscle weakness. So there's that would have happened. And in real life, I would have checked myself, because I know that I'm very vulnerable to what's called super excitement nerdy bias. And super excitement nerdy bias is when we, as especially people on VMR, when we see something that looks super exciting nerdy, we start to only focus on that. And we lose sight of the fact that real life is often real life and not super nerdy. So I would be checking my super nerdy excited bias and probably would like go in the bathroom, scream with excitement that this patient has something super fascinating. But then I would collect my thoughts, walk out of the bathroom, and be like anchored in practicality. And the practicality here is, let's explore the muscle weakness. The rash will only be helpful if we make more and more progress that the muscle weakness is inflammatory in nature, and that we've rolled out the simple things, med effect, so on and so forth. So my advice here, I haven't looked at the chat. I see that there's 16 messages. In real life, all of us would be going berserk at this case, especially since Alex is presenting it. Be careful. Real life always humbles you, and don't fall vulnerable to super nerdy excited bias. All right, Alec, back to you.
Awesome discussion. So I'll give you some labs next. In regards to the CBC, completely unremarkable, as well as the basic metabolic panel. In regards to the liver chemistry test, the AST was 99, with the upper limit of normal being 39 in our lab. The ALT was 74, with the upper limit being 52. The total protein was 7.1. The albumin was 4.4. Billy and alk phos were both normal. She had HIV and hepatitis screening, both of which were negative. The hemoglobin A1C was 9.9, normal being less than 6.5 for our lab. TSH and free T4 were normal, and her urinalysis was completely bland, and pregnancy test was negative. And let's see, what time is this? And just for the, I'll give you one more lab, and that was a CK, which was 2,186, with the normal being upper limit of normal being 223. And I can stop there.
All right, I'll reflect on the liver enzymes. I think they're really helpful, and then pass the mic for Prof. Rash to continue the weakness analysis he's been doing. And Alec, I might have misheard. Did you say the AST was 99 or 39?
99.
99. Okay, all right. So whenever you have an AST higher than ALT, you should stop and make sure that you're not dealing with a. Oh, you're welcome, Heather. You're not dealing with an extrahepatic source. So AST comes from the liver, but it can come in higher ratio from other spaces, including the muscle and red blood cells. So whenever you see this, you should step back and realize that you could be dealing with an extrahepatic source of AST. The common liver disease that does this is alcohol. And Here, the AST-LT ratio should prompt you to get a CK even if the patient wasn't weak. But more importantly, something I learned on the road with Prof. Rez, which is that it also is true that in muscle disease, the ALT can be higher than the AST. Why would that happen? The ALT has a longer half-life than AST. So if you had muscle injury from rhabdo 1 week ago, your AST will be lower than your ALT. So let's summarize what we know about liver enzymes and their ability to reinforce muscle disease. The most common pattern is an AST greater than ALT. Less commonly, in delayed detection of muscle disease, the ALT will be higher than the AST. But what will be universally present? Most patients will have a normal alk phos, normal bili, normal albumin, normal INR. So whenever you're working up acute liver injury without evidence of organ dysfunction, you should consider a CK. It's an easy, inexpensive test that will make sure you don't spend a lot of money erroneously following the liver when the problem is in the muscle. So my instinct now is whenever I see, no matter what, some hepatocellular injury with a normal albumin, a normal INR, and a normal bilirubin, I check a CK. Most of the time, it's going to be normal. The 2 times where it might be positive is when the AST is higher than the ALT, or as in this patient, when the patient already is telling me that they have some muscle issues. All right, and for the muscle issues, I'll pass the mic to Prof. Rez.
Awesome. Yeah, I think that's a killer pearl, Robbie, with regard to the long half-life of ALT. There's one other diagnosis I think we should have considered, and I was remembering NEJM clinical image, and that was, it was a patient that had like eye swelling, and they had Romana sign of Chagas disease. Romana sign of Chagas disease. There should be an NEJM case image if anyone wants to include it in the chat. And this patient is from an area where there is T. cruzi in Central America. So, but I don't have enough of a grasp of that illness script, and I don't think of it as causing this sort of rash that this patient's presenting with, or leaving a significant signature on the muscle enzymes. This CK elevation, we can now frame this case as a patient with muscle inflammation and skin findings. So myositis, as Robbie mentioned, dermato plus myositis. When you have a CK elevation, the severity is actually very helpful. So generally, when you have a necrotizing autoimmune myositis from a statin, or even a perineoplastic process, the CK is very high, like 40,000, 50,000. But I've seen necrotizing autoimmune myositis with a CK of just 2,000. And that was in a patient who had it for 2 years before being diagnosed with this condition. But that patient lacked muscle. All that muscle was, atrophied from the long chronic process. So when you are approaching inflammatory myopathy, you can use the IMAID mnemonic. Think of infection, cancer, autoimmune disease, drugs, endocrine disorders, and electrolyte disturbances. Here, we really don't have much going for infection in terms of the temperature, the white count, and just the flavor of the case. Malignancy and autoimmune is really interesting in that some patients with autoimmune diseases is due to an underlying malignancy, and they're presenting through a perineoplastic phenomenon. So it's not always the case that you fall into one bucket, but sometimes 2 buckets are linked: cancer and autoimmune disease. The patient's medication, the atorvastatin, again, you think about necrotizing autoimmune myositis, but it's just not giving me that flavor with the cutaneous manifestations, the low elevation in the CK. And endocrinopathy, some endocrinopathies like thyroid disease can cause sudden onset weakness and elevations in the CK. And then electrolyte disturbances from low phosphate levels to low potassium can also affect muscle function. So where am I now? I would probably be in the dermatomyositis. Like, this wouldn't be polymyositis. It wouldn't be inclusion body myositis. It wouldn't be necrotizing because you have the skin findings. So to me, this is dermatomyositis, but the journey doesn't end there. Meaning, is there an underlying malignancy? And there's been so many perineoplastic antibodies linked to dermatomyositis, that it's worth, doing whatever the recommendations are for cancer screening. So this patient needs a muscle biopsy. You might get an MRI first to show the edema, and then sort of plan a site for biopsy. And then in the biopsy, we'll see if there's features with the CD4, CD8 lymphocytes and their invasion of the muscle, whether it's consistent with dermatomyositis.
I didn't know Reza was a secret pathologist too. CD4 and CD8. Oh my gosh.
I'm just throwing random names out there, hoping that no one is a pathologist in the audience. But I'm nervous. Nilayan, I do see, before I give the mic to Alec, you commented on, could CMV be I think that's a beautiful thought when you start thinking multiple organs, skin, liver, lung, eyes, muscle. Terrific thought.
All right, excellent. I think maybe I didn't clarify the history there. So I think the Romagna sign is really associated with acute Chagas, and she's been in the US for 30 years. So I think I apologize if I didn't mention that.
Don't apologize. You just taught me that Romagna sign is for acute Chagas. I just knew it existed. Thank you, Alec.
Sure, of course. So I'll give you a little bit more information. So she did throughout her hospital course, her weakness wasn't really that pronounced. But we did get an MRI of the bilateral thighs, which showed diffuse muscle edema involving most of the muscles in the thigh, but most prominently in the adductor muscles. But there was no atrophy or really any other significant findings. And let's see, I'll give you a little bit more information as well in regards to labs. An aldolase was checked, which was 18.4, the upper limit of normal being 10 for our lab. And ANA was negative. Complements were negative. She had an anti-double-stranded DNA, anti-Smith, anti-RNP, SSA, SSB, and anti-Jo1, which were all negative. And had an HMG-CoA reductase antibody checked, which was also negative. And I'll stop here, and the next Alcott will reveal the diagnosis.
All right, mic to you, Robbie.
CD4, CD8. I'm still on that right now. Yeah, I think this is super helpful. I think the MRI confirms the possibility of myositis, and it's helpful because the imaging characteristics can actually land you in the inflammatory category and move you away from all the other stuff you have to entertain that Reza outlined earlier. And I think the question is, as we move towards the myositis train, what do these negative tests do? And the truth is that that ANA is only positive about 30% of patients with inflammatory myositis, so that's very helpful. It makes lupus very unlikely, especially with the negative double-stranded DNA and anti-Smith. Anti-Jo antibodies are great test for anti-synthetase syndrome, which is characterized by muscle features, but also fever, Raynaud's phenomenon, skin changes that are a little bit different, and then some muscle, lung findings, excuse me. So I think at the end of the day, you need histopathological analysis to confirm the diagnosis of dermatomyositis. And the truth is that our understanding of the subserologies of dermatomyositis is expanding rapidly to the point where we actually call it a subset of dermatomyositis, and then it moves away from being called dermatomyositis. That's the story of anti-synthetase syndrome. Anti-Jo was thought to be a subset of dermatomyositis. And then we discovered that the syndrome of anti-synthetase antibodies is a little bit different. The two other ones that I know of, because we've seen patients here with them, here meaning in San Francisco, is anti-MDA5. Anti-MDA5 is a devastating form of an inflammatory myositis characterized by rapidly progressive lung disease and ulcerating skin lesions, which this patient doesn't have. What this patient might have accounts for 20% of dermatomyositis, and it's called anti-NXP2 dermatomyositis. And it's one in which the rash is prominent and the edema is very prominent. And they also tend to have dysphagia. So what's the story? The story that you should know is that the ANA is often negative, that the subserologies are ever expanding and complicated and may separate out into different diseases. And if you want to arm yourself with one buzzword about the three most common one, anti-Jo is described as new syndrome, anti-synthetase antibody syndrome. anti-MDA5, rapidly progressive severe lung disease and ulcerating skin lesions, and anti-NXP2 is a high rate of dysphagia, high rate of distal weakness, and a lot of edema. At the end of the day, none of that prominently matters, with a caveat that morbidity and mortality is actually linked to the kind of antibody you have. So it matters for the experts, the rheumatologist, but for people on the diagnostic arm of it, I think you want to look at those CD4 and CD8 lymphocytes. What else do you have to add, Prof. Rez?
I really have nothing to add. And I think what you just did shows us that our learning never ends. And even though we're not pathologists, like you just educated all of us, and it does make a difference for the patient. So we need to be knowledgeable how these antibodies affect prognosis. So thank you for teaching us, Robbie.
All right, awesome. So the next test that we have was a punch biopsy actually of the chest rash, which showed vacuolar interface changes with occasional necrotic keratinocytes and intradermal lymphocytes. And there were some mild perivascular lymphocytic infiltrate with some edema in the dermis as well. And basically the pathologist called this interface dermatitis. I can stop here, or I can give you the next test that reveals a diagnosis. I can, whatever you prefer.
Yeah, I'll just say this, that interface dermatitis is not pathognomonic for any specific diagnosis, meaning patients with drug-induced hypersensitivity syndrome may have interface dermatitis. So I'm curious to know, Alec, did you guys proceed with a muscle biopsy, and how did you make the decision to go after the rash versus the muscle on the MRI?
Yeah, so actually getting an MRI can be somewhat of a logistical issue at our hospital at times. And so getting a punch biopsy is actually quicker. And then with the findings of interface dermatitis, and then we did a myositis specific antibody panel. And I had never heard of this, but then Robbie just mentioned it. And so it was positive for anti-NXP2. So with her clinical syndrome, with the rash, which dermatology felt was very consistent with the heliotrope rash and the Schall sign, which is highly specific for dermatomyositis. There's really not much else that can cause that. Plus the anti-NXP2 and the findings of interface dermatitis, which is non-specific, but highly associated with dermatomyositis if other features are present. We diagnosed her with dermatomyositis.
No, there's so much to reflect on this case, but I just realized you made such an important point, because I didn't even think of biasing the skin rash, because I also had the same association that Reza had. But that one insertion that you said in the specific context is so helpful, because if you just biopsy at random and you get interface dermatitis, you probably are none the wiser. But in this case, it's intriguing to know that it helps you build even more of a case for dermatomyositis. And I think there's so much to learn and reflect on this case, but I would emphasize the one thing that Prof. Rez says, which is the journey doesn't end here. You have to sit back and say, hey, what did this? And could this be a perineoplastic process? And I'll share with you one fascinating pearl that I learned on subspecialty VMR, which is, I say for two reasons. One, to plug it, because Alec is going to be on it soon as part of the Rezai twins on our Monday subspecialty VMR. Led by our fearless leader, student Dr. Rafa Medina, who is here and probably blushing and turning away from the screen. I can't see him though. The pearl that I learned from that is that there's this theory that all these autoimmune diseases, including dermatomyositis, are actually triggered by a cancer, that all of them are. But a fraction of them remain, and most of them are killed by the immune system after unleashing an autoimmune attack. And there's a fancy word for it that I don't remember. I'll have to review it. But it was a humbling sort of scientific reformulation for me that most of these perineoplastic syndromes, which we associate with variable rates of perineoplasia, all of them began with an occult cancer. Most of them, the immune system was able to fight back, and in the process of fighting back triggered autoimmunity. So it's a really interesting formulation of how these diseases begin, and they may all begin with an occult cancer that thankfully the immune system is able to battle, but unfortunately there is friendly fire, and that friendly fire may result in an autoimmune disease. But for me, it's a great reminder to always step back and say, in this person with autoimmunity, um, could they have a cancer? I think that Reza bringing up that point early on is really, really important. All right, I'll pass the mic to you, Prof. Rez.
No, that's really interesting. Pathophysiology. I'm really curious to hear from Alec if they did do any screening or if any tumor was identified before passing the mic to Shema to take us home with some teaching.
Yeah, so I actually saw her after the diagnosis was made and came in, unfortunately, because she was having a flare of her disease. But so she got completely pan scanned, chest, abdomen, pelvis, nothing there. Was actually already up to date on her pap smear, which was negative, and had yearly mammograms, which were okay. Still has not had a colonoscopy, so that is in the works. But so far, no clear evidence of malignancy that we've been able to find. But she is on, high dose prednisone and azathioprine, and actually received some IVIG after she represented, and is overall doing better. So I'll just be following her case. And yeah, thanks for teaching and allowing me to present.
Thank you, Dr. Rezi. All right, Shema, mic to you, my friend.
Hello everyone. So excited to talk about a teaching point. It was a great discussion and very amazing case. I have heard this NXP2 never before. So coming to the quick teaching point. So we were having the chief complaint of weakness, and the key question is it true weakness, or is it rather a sensation of weakness? So where we don't have a true decrease of muscle power, referring as asthenia. And also consider the time course, as we know. And another question for weakness: do we have any kind of upper motor neuron lesion, like, or is it a lower motor neuron lesion? And for this, for a sign of the first motor neuron, look where we have any spasticity, and as a second motor neuron involvement, fasciculations. And then we were talking about rash, and important is like looking at red flags. Do we have any ulcerations, and also consider the depth of the lesion, the distribution, like any sparing of the nasolabial folds, which is common in dermatomyositis, or do we have any sun exposed areas like in lupus? And also consider to check areas that are usually not looked at, like the neck, knuckles, thigh, axilla. And also for facial involvement of rash, Rabi taught us consider zoster, cellulitis, odontogenic infection, and also do not miss SVC, angioedema, anaphylaxis. In terms of periorbital swelling, as we know, we consider dermatomyositis, trichinella, and also what Reza told us, consider Romagna sign in acute Chagas. And what Kirtan told us in the chat, in terms of an involvement of skin, tongue, ocular tissues, esophagus, and weight loss, consider any kind of small vessel vasculitis, IgG4 related disease, SLE, and also mimics like endocarditis and other infectious diseases. And also coming to the fact that we had a face and leg involvement, we weren't thinking about a brain involvement, we were rather thinking about a proximal muscle issue. And then we were talking about atorvastatin induced necrotizing myopathy, as it usually makes a very high CK, and the muscle injury still continues after stopping with the statins. And here we have like there are HMG CoA reductase antibodies. And then another point in the chat in terms of diabetes mellitus together with a pruritic rash, weight loss, and diarrhea. He was no diarrhea, but if he had, we would consider glucagonoma, which is but very rare. And then the patient had normal reflexes, so we weren't thinking of an upper motor neuron lesion, rather of a peripheral nerve issue. Oh no, not of a peripheral nerve issue. And then we were mostly thinking of myositis, so check CK, aldolase, AST, EMG. And our clue was thinking of dermatomyositis, and in terms of dermatomyositis, consider is a paraneoplastic, and we have a proximal muscle issue, and also what Reza taught us, consider in terms of muscle biopsy an elevated CD4-CD8 ratio. And then we were talking about elevated AST, and if we know when the AST is much higher than the ALT, consider an extrahepatic source of AST. What Ravi said, like AST can be from the liver, but also from the muscle and the red blood cells. And if it's from the liver, we usually think of ethanol. But what we are also told is ALT can also be higher in muscle diseases in delayed detection because it has a much higher half-life. And if we have AST elevations with normal other liver labs like Billy, INR, albumin, we should always check CK to check whether there is a muscle issue. And for inflammatory myopathy, consider the IMH mnemonic. And then coming back to the myositis, what we learned is the ANAs can often be negative. And in terms of anti-Jo1, it can be an anti-synthetase syndrome where we have lung involvement in heterologia together with myositis. And for anti-MDA5, consider rapid progressive severe lung disease together with ulcerative lesions. And what we also learned now today for this case was an anti-NXP2 dermatomyositis where we have dysphagia. It can also present with calcinosis, and we have proximal and distal weakness, edema, and it is also often paraneoplastic. So thank you very much and see you again.
Bye, everyone.